Hi, I welcome all of you to another episode of Scaling Vision podcast. I'm so excited to host none other than Dr. Shubhangi Bhave, a very senior consultant from the world of ophthalmology in Nagpur. She specializes in pediatric squint and strabismology. We're going to talk to her about the latest SPOSIVUE conference that was held in Nagpur under her presidentship. I welcome you to the podcast, ma'am.
Yeah, thank you, Samir.
Ma'am, let's talk about the latest developments let's talk about the SPOSI view that happened this time. Walk us through what was discussed, any key elements that we should be knowing about the latest advancements in pediatric squint management.
Yes. So, this SPOSIVUE, of course, many aspects were developed, but some recent ones which we deliberated was on amblyopia management. There were some nice papers on amblyopia management and how improvement in amblyopia improves the fine motor skills in children and various modalities to manage amblyopia in a better way. Then in the pre-conference workshop, we had a section demonstrating about the Binox, which is a latest treatment in the management of amblyopia. Myopia was discussed in great details. As you
Right.
know that myopia is a
Silent epidemic.
yes, and growing to a pandemic proportion. So they say that 2050, by 2050, about 50% of the children would be myopic. So
That's
it's
a
that
huge
high.
number, ma'am.
That's a
That's a
huge number. And we had a session, 45 minutes session on which the pathophysiology, the various modalities, the newer techniques and technologies, the DIMS glasses, and we are even getting 0.5% low dose atropine. That was all discussed. Orthokeratology talk was nicely given. That is another modality of treating myopia. Then genetics is a next
Right.
new kid on the
CRISPR and all
new kid on the block, and we had some discussion to that, and botox, botulinum injection.
right.
So newer modalities of management of
This
squint.
seems exciting, ma'am. So let's
Yes.
let's talk about the most important topic. Why not myopia? How are things changing? 50%. That's an alarming rate. Even I think the newer
Yes.
parents, new age parents, should be very much aware about all these things. And
Yes.
screen time is increasing. School time is slowing down. Kids
Yes.
are not playing outside nowadays.
Yes.
So what are we looking at?
Yes, so that we realized first time in the COVID pandemic, that people came to us with one of the patient came to with minus 3.5 diopter as the first number.
How old was the child, ma'am?
She was 12 or something, and because she was not seeing beyond her screen, so she didn't realize
Right.
that she has such a big number. So that is how excess of near work and all those things, and excess of screen time, total lack of outdoor activities nowadays.
So, ma'am, as we general ophthalmologists know that if the cycloplegic refraction there is a difference of 0.5 diopters within a span of 3 to 6 months, so you are supposed to start low dose atropinization. If that does not work, how do we move ahead next? What are the different modalities?
Yeah. So apart from low dose atropine, we have the DIMS glasses. Basically, the theory that why myopia progresses is the peripheral hyperopic defocus, and these DIMS glasses, the double incorporated multifocal segments, they tackle this peripheral hyperopic defocus because they have a lesser myopic number at the periphery, and that is how the progression is reduced. So they have the low dose atropine and DIMS glasses have synergistic actions. One works on the afferent arm, one works on the efferent arm.
Right.
And so this is how we can combine low dose atropine with DIMS glasses with lifestyle modifications and all these
Ma'am,
things.
the question arises: is other prescription of DIMS glasses? Is there a economy segment that comes into picture? Are these glasses expensive?
Yeah, they are
So,
expensive.
right.
Currently between 10 to 15,000 per pair, but the companies are making it easier for us by offering some discounts and giving a glass free if the glass breaks or the prescription changes within a year.
And how frequently are DIMS glasses supposed to be changed? It depends on depending on the changing
Yeah,
prescription.
so
Once a
at
year.
least once a year.
Once a year.
Yeah.
Okay. Most parents are not even aware, ma'am, that my child has glasses.
Yeah.
Let it be hyperopic correction, myopic correction, astigmatic. First thing is denial.
Yes.
Denial is a
Yes.
very big thing. Uh, what are the key indicators every parent should know that if my child is showcasing these four symptoms, five symptoms, I should go talk to a ophthalmologist?
Yeah. So basically, the visual behavior of the child. If the child is seeing the TV from very close, or if he's squeezing his eyes and seeing, or tilting his head and seeing, could point that he is not seeing as good as he should be. Plus, if there's some squint or some other such things. So as a routine, I think the child should be examined before his or her admission to the nursery class for a
That's a
for
wonderful idea.
a refractive error,
Right.
because certain types of amblyopia, if detected that age, can be treated very nicely.
Definitely. This is something that I have observed in my OPD. Some parents, old patients, we have been seeing them for 3, 4, 5 years. Uh, they self administer a low dose atropine बच्चे को घर पे. And I'm not sure how to respond to such parents.
Yeah.
I'm sure other ophthalmologists must be facing the same issue. How do we counter this, ma'am?
Actually, there is, like, I think a bad advertising or bad marketing of the low dose atropine. Not only the parents, I have seen doctors prescribing low dose atropine for any pediatric eye conditions.
Oh, okay.
So last week I had a patient who was a high hypermetropic. He was for 3 years on low dose atropine.
What happened, ma'am?
Low dose atropine is given in paralytic squints. Low dose atropine is given in any format of squint. So actually, whenever you're using a drug, though we say there are no side effects,
There are
one
bound to be
should
effects.
know
Right.
about the indications of that drug and proper usage of that drug before it is used.
Do you think we should make this drop available only prescription based?
It should be.
It should be
It should be
prescription.
only
I
prescription.
think that's going to help a lot,
Yes,
right?
yes.
Moving on to the very controversial segment, ma'am. In your practice over the years as a pediatric squint consultant, what do you see the common mistakes general ophthalmologists are making in dealing with pediatric patients?
Yes.
Or sometimes too late of a referral is also
Yes.
or such points that you're seeing.
Yeah.
Please let us know, ma'am.
Yeah. So basically, most of the general ophthalmologists are not too much aware of the ophthalmic conditions. So they will tell the late referral is one of the very common that the child will grow out of it, can be operated only by 10 years of age or 5 years of age. So apart from squint, the presence of squint could harbor a serious ocular problems. So many patients referred to me for squint have a unilateral cataract,
Right.
congenital, have a unilateral. One of my patient had an absolute glaucoma. In one eye, had a divergent squintus. Kid of 7 or 8 years old. He had a congenital glaucoma with
That's a very gross error.
no PL in one eye and had a divergence because of that, and was referred as squint to me when nothing could have been done. They have tumors in the eye. So all these serious issues also can be just squint, stitch up, and nothing can be done. So that sort of mentality has to change. So these are various problems we face.
But then why not buy platforms like SPOSI
Yeah.
on a national scale, and every city has its own glaucoma club,
Yes.
cornea club,
Yes.
squint club, cornea club. So why not, when you have your city ka CME, we have a session where somebody like you can teach us, the general ophthalmologist, ki bhai, this is what you're doing wrong,
Yes.
and this is what you need to correct yourself.
Yeah. So those things should be there, but the general trend in general ophthalmologists is to attend either a cataract session or a glaucoma session. They feel squint. We are not going to do it, so why attend?
Right.
So everyone is into phaco and refractive surgery session, and very few takers for the squint session. So I'm glad this conference, so many general ophthalmologists registered and
Right.
attended, and we had good conference. We had
It
good
was a massive success. A lot of my
Yes.
friends who were attending it, they were very happy
Yes.
about the newer things that they learned over here. So congratulations for the conference.
Thank you so much.
Tell me about your story, ma'am. How did you get into ophthalmology, and when was this? ऊपर से such a difficult specialization in pediatric squint strabismology.
Yes.
Tell us about your journey, ma'am.
Ophthalm, I was always interested in ophthalm. Initially, I was interested in pediatrics, but somehow couldn't do very well in medicine, spoilt my viva in medicine. So then ophthalm I did well and took up ophthalm as the subspecialty, and as my luck would be, went into pediatric ophthalmology. It was more of strabismus in those days rather than pediatric ophthalmology. We had my training at GMC. We had very good teachers in GMC. We had Dr. Harminder Dua, and he used to experiment a lot.
Was he your batchmate?
No. He's very
You're
senior to
you
us. He's 69 batch, so
Oh,
it's
okay.
7 years senior.
And you
to
are
us.
76 batch. Okay. Nice.
So he used to create these after images, put black paper on the camera, create the images in the eye, and then create those after images. And he used to do a lot of experimenting. So somehow that clicked, and I thought I should go in for strabismus.
And so where did you meet sir? In GMC only?
Yeah, he was he
Your-
was our lecturer.
Oh, okay.
Yeah,
Nice,
sir
nice.
was our
Very
lecturer
nice.
when we were in GMC, and then we had this interzonal visiting fellowship, and Karandikar sir encouraged me to go and take up that.
So Dr. Karandikar sir taught you, he was your
Yes.
professor. Kya amazing.
He
That
was our
wa-
mentor.
Right. What then, ma'am? How did you immediately jump into private practice?
No.
What happened
I
then?
was for 9 years. I was working as an associate professor at GMC. So after my MS, I had that interzonal visiting fellowship. That was 3 weeks fellowship. So I said I'll take up strabismus. So I was sent to Aligarh. At Aligarh Muslim University.
What year?
Dr. B.S. Goyal. That was 85.
Right. Okay.
And so on coming back from there, Karandikar sir said that Squint Clinic is sort of lying dormant, so revive it. So we started on Wednesdays at 3 p.m. We started our Squint Clinic.
Where in Ramdaspet itself?
GMC.
GMC itself.
GMC itself.
But when did you venture into private
journey,
practice?
I ventured in 94.
94.
So till then I was at GMC long 8-9 years, and I had loads of patients. So did a lot of work there.
And when did you get married? You met sir, and usually ophthalmologists marrying a very renowned, such a national faculty of a psychiatrist. When did that happen, ma'am?
It happened long back.
Long back.
82.
क्या
My
बात है?
husband says I was married in the Palna.
क्या बात है? So
we were into going steady since.
Oh, you were dating to the
79.
Oh, that time when dating was not a very trendy concept then.
Yeah.
So now you've shifted to new premises. I think it's almost less than a year up tak.
2 years, almost. It will be
Right.
2 years.
So what was the thought process? Why changing locations for any doctors after 25, 30 years of practice? It's a huge risk is the word that
Yes.
comes to the mind. Tell me what was the thinking process? Did you lose some patients and when you accept that I'm going to lose this many patients, you gain on the newer side also? Tell
Yes.
me all those thinking processes, ma'am.
Yes. So we were at the central portion in the market, so to say, Ramdaspet area. To leave that area and go to the
A little peripheral,
periphery
right?
was scary, but there was a lot of space constraint at the Midas sites where we were working, and we couldn't acquire more space there. And since both my daughters were joining me, the elder one is a psychiatrist and the younger one is a psychologist, they needed some expansion to be done. And even I felt that making changes into my infrastructure were difficult staying in that place. So we had decided to shift, and our building was also becoming old at Midas, so there was a need to change. Luckily for us, since both of us, my husband and myself, we shifted, he has a large patient base, and some 5-10% patient must have been lost, but where we shifted is a thickly residential area, and so I'm sure we have got a referral from that patients also. There's no big hospital in that area, and a hospital which is equipped with all the equipments and everything. So luckily for me, there's no dearth of patients.
Um, what happens when you change the area? Are you supposed to take all the permissions for OPD hospital all
Yes.
over again, or
Yes.
you just are able to shift the old registration to a new place? Is that allowed?
No, it's not allowed. We have to take new sanctions
All over
for
again,
everything.
and
Yes.
I'm sure you must be NABH compliant
Yes.
and all those things
Yes.
again. Nice.
So that was a big thing. What we did is right from about a year back or 1.5 years back, we had printed some labels in which we put on our patients' files that this hospital is to be shifted to a new place. So,
so
many of our patients also knew that we are shifting.
So prior to making a shift, you were already reinforcing the mind of the
About
patient.
1.5 years back, we were, because it takes a long time to build a new place. And
So probably that must be the reason why you have such a low
yes.
patient loss. You've made the very conscious efforts to inform your people that I'm patient that I'm leaving and changing place. Nice.
And then in our old place also, we kept a person for a year with the address for the new place.
Okay.
So he used to direct the patients, whoever wanted to come to the new place.
There was a huge billboard in the city somewhere.
Yes.
I saw it at particular square. Huge. That was such a wonderful idea, and there was a QR code.
Yes.
I think it was a link to a Google Maps place.
Yes.
Wonderfully executed
That we
things.
did for 3 months
Right.
after we shifted.
Nice. Where do you think the future of strabismology and pediatric squint is going?
Yeah.
AI. Is there any use of AI in this particular field?
Yeah, of course. AI would have its use in, I think, every field. I see a bright future for pediatric ophthalmology and strabismus. The cases are definitely increasing. There are many new techniques and technologies which are making the field more exciting. So we have imaging, like the UBM, the ASOCT, dynamic MRI, all these things are making things very exciting in certain cases of restrictive squint, in cases of resurgery when you can locate the muscle. And then some new concepts have come through imaging, like pulley dysfunction, then the alteration of muscle path in high myopes. So all these things have made treatment more exciting.
Exciting, right?
Yes.
Do you think there are these newer modalities that I'm aware about? Those are called as myopia progression analysis.
Yes.
Or we have uh, nowadays people are doing topography. Topographies are also coming up with progression
Yes.
analysis. Is this going to help further? I'm sure
Yeah.
they are going to refine it further as
I'm
things goes on.
using, yeah,
Right.
I'm using one, the Topcon one, the Maya app.
Right.
So that gives an idea of at 20 years what would be the myopic refraction. More than anything, this is a warning to the patients, or they see it on paper that, oh my god, my son is going to be -6, my son is going to be, my daughter is going to be -5. So probably that makes them more aware about the lifestyle modifications which we insist, and all those regular follow-ups, because I see most parents think that, oh, if I go to the doctor the number will increase. So they avoid going to the doctor, and
This is something I think everybody faces nowadays,
yes.
right?
So, and moreover it causes more harm, because
Right.
if you're wearing an undercorrected specs, the number will definitely increase rather than if you're wearing a correctly given spectacle.
This is a question I ask a lot of every doctor who comes over here. If not a doctor, what profession would you have chosen?
I've always thought of myself as being a doctor by being a family of doctors. But I think I would have been a good cook,
क्या
chef.
बात है? So
I love
क्या बात
cooking,
है? Lovely.
and so and
Very nice, ma'am. Um, thank you for being here.
yes.
It was so lovely talking to you.
Yes.
Uh, I was actually very um, what's the word that comes to the mind? I was very scared कि मैं मैम को बुलाऊं कि नहीं बुलाऊं. Will she agree? Will she not? Because to me, whenever I've met you, you've come across this very strict authoritarian kind of a person. So मतलब चल, I made all the effort. चलो गणपति बप्पा मोरया, let's just call ma'am. So thank you for being here. This was so fun talking to you.
Yes.
Anything that you want to talk about more?
One thing I would like to talk about in this conference, as a way to pay back to the society which has honored me with its highest recognition, I have converted many of my surgical videos into a Google Drive.
Okay.
And I have made a Google Drive of these videos, which I'll share it to the PGs and everyone who attended the conference.
So nice.
So they can have a look at these are teaching videos.
Right.
From about 24, 25 videos we have converted. Dr. Saili, who is with me, has been a great help in making these videos. And this I'll share it with everyone so that they are of help to the postgraduates. And
She's my best friend's younger sister, so
I
so she's doing great. She's a big fan of yours. So I wanted to talk to her about basically what you talk, how to talk to you, and wonderful feedback. She's a fan of you. I don't think she's going anywhere.
I hope so.
Thank you so much, ma'am.
Yeah.
Thank you for being here.
Thanks a lot.
Keep on watching, please. If you want to talk to ma'am about anything, just drop in a comment. We'll reach out to ma'am for you. Thank you.